Absolutely. Thank you for having me. And I am quite happy to talk about stool testing and particularly stool testing from doctors' data. I've been in the industry for 20 plus years. I've watched a lot of what's come around. Like was mentioned in the bio, I work at Progressive Medical, and it's a large integrative clinic in the Southeast, literally brick and mortar for over 25 years. So being able to watch thousands and thousands of patients come through there and really looking at what helps people to get better. And a cornerstone of what we do there is to make sure that almost every patient has a stool test. Of course, when clinically indicated, it's not a protocol or mandatory, but it is so often clinically indicated. And what I wanted to talk about today was that scenario where, like, you are having horrible abdominal pain, 20 bowel movements a day. We're going to get the stool test back. It's going to show the pathogen. We're going to know what is going on. We're going to see the bug. We're going to treat it. And this is going to be better. And then you get a test back and you don't see maybe the pathogen that you were looking for, but yet then where are these symptoms coming from? And so there's so much our stool testing can tell us that is not merely wrapped up in pathogen or no pathogen. And this is a mistake that I used to make, thinking, oh, well, you have no microbiome, no short chain fatty acid, but no pathogen. So this is pretty good. And that is not pretty good. In fact, having an absence of your microbiome is as bad as any pathogen. Like, we know that here. We know all the data that we read about lactobacillus and bifidobacter being anti-inflammatory, but somehow when we see that on a piece of paper, we're very caught up in kind of a standard of care model, right? A bug, an ill, we're going to kill it, they'll get better. And the idea of boosting the person, boosting the microbiome, well, is where integrative medicine really steps in, and embracing that when we see it on our stool testing can be so useful. So we're going to talk today. I'm going to walk through this. If you like what you hear today, go check out Origins Incubator. This is where I do my year-long clinical teaching. We have a cohort. It's a practice management group. I do that with Scott Radigan, functional lawyer, as well as Linda Mattioli, who had a wait list after 6 months after moving to a new town. And so we talk about what we've all done together, and we give you all those tools. And this is a bit of what we do. So in Origins, as you're getting started, people submit their case studies. We talk about what should be done. We talk about what testing should come next. And you wouldn't be too surprised probably, but so often, even with the most complex case, we're talking about how we have to still look at what's happening in the gut, what's happening with a stool test. And I know we all know this to be true, but that's something that's kind of really crystallized in my brain is that the number one way to boost immune function or to balance immune function in a human isn't a beta glucan or a vitamin C or a vitamin D. It's nothing singular in a bottle like that. The number one way to boost immunity is to improve gut-based health, to improve the microbiome, to improve secretory IgA. In fact, there's literature in the oncology space that talks about one of the major reasons for reoccurrence is that the immune system doesn't get stabilized. And it's not the white blood cell count. We've seen plenty of people status post chemo. We know that comes back. What they're talking about was the assault to the microbiome. And if we don't reestablish that, then there's going to be a risk of recurrence. So the absence of lactobacillus, the absence of bifidobacter is just as meaningful as a pathogen, particularly in our cancer patient and or any patient that we want to have immune balance. So when we are working in a functional medicine paradigm, we are thinking about, sure, ICD-10 codes and a diagnosis, absolutely. But what's the process behind that condition? And so that process behind the condition, no matter if it's depression or cardiovascular disease, we want to reduce inflammation and oxidation. We want to improve nutritional levels. We want to minimize toxicity. We want to minimize stress and improve diet and lifestyle. And when we do those things, most of what we treat is going to see improvement with it. And many of these things get us right back to what's happening in terms of our stool testing. Even toxicity, right? A healthier microbiome is going to absorb toxins before they get in the body. Arsenic, for example, they did studies with women who are pregnant. The pregnant woman who got the probiotic in a yogurt form had kids with less developmental delays than those who didn't. And what they saw was that was because they absorbed less arsenic, less lead, because of a healthy microbiome. So toxicity, that's true. How about our mold patient, right? One of the best ways to keep aflatoxin out of the body is a healthy microbiome. Lactobacillus absorbs aflatoxin right into the cell wall. Saccharomyces right into the cell wall. So you get back a stool test on a mold patient and they don't have a pathogen, but have a real, their microbiome is struggling. That is a pertinent positive. We shouldn't feel like we didn't find the thing that we were looking for. So we know that we're even figuring out that there's bacteria even as far up as in the stomach, right? Good, healthy flora. If H. pylori could exist there, it would make sense that we would evolve with things that are healthy there as well. And then as we move through the gut, most of the bacteria that we're thinking about more large intestine. So this is the GI 360, and at Origins Incubator, where I teach the clinical curriculum, when people ask, what is my go-to stool test, which comes up all the time, this is the one that I point people in the direction of. And like I said, I have the advantage of being in this space for 20 plus years, working very closely with laboratory studies, looking at patient care, what's going on. And so really understanding that I get the best results with this test. And that's not just me. I think that we see that throughout we see that in the peer-reviewed research, for one. And this is not something that we get a lot of, but there was a paper published from Baylor, and they looked at stool testing in the general community. And they did split specimens, and then they also sent the same stool to multiple different labs, and they knew what was in there too. You can spike it. And so then see who got the most reproducible data and what matched what was in the spiked specimen. And doctor's data was at the top of that. And then from there, I don't like to choose. I want a little bit of everything, right? I want PCR. I want a genetic test that's going to show me all this flora, that's going to show me right down to a little speck of DNA. But is a little speck of DNA from one bug clinically relevant? So that's the culture. Now, if it shows up and it's pathogenic, it gets grown out. And so the sensitivity is specific. So if you're working with something that's only PCR, what you're seeing, if they show something that looks like sensitivity, they're not growing out that bug and putting each agent next to it. They're saying, in general, here's what this bug responds to. Well, our patients with chronic conditions, these bugs have mutated, they've changed. We want to know exactly what they're going to react to. So to me, this is the permutation. It's the beauty of both sides of the world. Also, I think when we hear culture, we tend to go, oh God, that's what I did in med school. I streaked an agar plate. I watched things grow. That's not that sophisticated. True. That's not that sophisticated. It's accurate with certain bugs and whatnot. But my point is that is not what's happening here in terms of culture. So with that culture, the method, and that's another. So when you're out there, not just but you evaluate what's out there. How do you can choose? The evidence, peer-reviewed data. So MALDI-TOF, for example, is highly peer-reviewed. That's the methodology. And so with the culture, that's a process that allows you to break things down to messenger RNA levels. And so really getting a very specific look at what's happening in terms of bugs there. So culture on steroids plus PCR. And I think that this gives us a a really reputable test. And then again, like I said, looked, because a lot of stool tests out there are, for example, their own homegrown methodologies, something that they're doing in-house that the lab has developed itself. And there's nothing inherently wrong with that, but then you want to see the studies that correlate that to a known methodology or to a known fingerprint, or do they have the studies where they spiked it with certain things and the recovery and whatnot. MALDI-TOF, we go to PubMed, we see thousands of studies, and so we know that we are working with something that's highly evidence-based. So this is the first page of the GI 360, and I like this because it gives us a nice overview of what's going on, and what you really want to see is more towards the center of the bullseye, right? You're just not looking for something that's pulled out in any one direction too much. So for example, and all of these areas have benefits and cons, pros and cons. And so again, we want to be just more diversified. But if you were going to ask me, I find these guys to be a little more beneficial, as this is more where your bifidobacters and your lactobacillus and your fecal bacteria prenensis, that's where these lie. And so these tend to have a bit more data. So when I see things more pulled out in this direction, I'm a little more concerned about the balance of flora there. And while we're going to look at the line by line, and whatnot, it's fun, it's intellectually engaging. However, I don't think it's that necessary for patient care, because really the bulk of the data at this point is still diversity. And so what we want are things in balance. And so I don't think that you really have to spend a lot of time looking up this bug and what it does and this bug and what it does and this bug. Yeah, sure. If something's way, way out of balance and they're a huge outlier, it's interesting to know, and it's so outside the bounds that, okay. But in general, just are people towards the midline? That's what you want, a nice balance. And this helps us with some ease in terms of going over results. I wouldn't bother getting trapped in the line by line of each bug. It was probably not clinically meaningful to an extent that we can extrapolate from it at this point. However, what is clinically meaningful is diversity and being in balance. That is not too debatable at this point. So we can look at these various groupings and types of bacteria. We can break things down into what are known as maybe various gut types. We know that certain bugs will break down more carbohydrates, so could contribute to weight gain in that way, or might erode the mucus lining of the gut, which could increase gut pain, or might cause us to also absorb just more, not more simple sugars, simple carbohydrates. So again, we can look at these patterns. And so, for example, that Provotella, that is this one that breaks down your mucus lining, is in that proteobacteria category. So when you're trying to kind of connect that to what's going on, so kind of looking back at these and thinking of it from that direction. So if you're super high in that area, that can be associated with insulin resistance, obesity, or hypertension. Wait, what? If you're super low in that area, that's Crohn's and Parkinson's disease. And so it's like, well, is it good or is it bad? And I know that is what we are so hungry for. Is this a marker that when it goes up, it's bad, goes down, it's good? But it's much more like a white blood cell count, right? There's problems when it's high and problems when it's low. We want to be in balance. So again, don't get like too distracted by the line by line. What's the diversity? What's the balance? Okay, so Ruminococcus, beneficial bacteria. It is in that Firmicutes area, but it can be mucin degrading, as even Akkermansia can be. Well, and that's confusing, right? We get back a high Akkermansia on a stool test, and we are thinking, well, wait a minute. It's supposed to be good, right? Because it decreases cardiovascular disease. We use it. It helps with people in the cardiometabolic continuum. But now when we see this, so it should be good. So what do? Treat a high Akkermansia? Do we kill it off? Well, no. Why is it out of balance? And it could be responding to inflammation in the body, really just working on the microbiome in general. And we know, for example, like I said, even though Akkermansia has a lot of cardiometabolic metabolic activity to it. If it gets too high and out of balance, it can chew the mucosal lining. So again, not good or bad. What's the balance with it? And so we can find these various connections, but ultimately really working on the patterns, not the specifics or where we want to be. So we know that that the bacteria, those are some that can be more variable than other bacteria out there. And so then that will lead us to our dysbiosis index. And so this one for demonstration comes back high, 5, over in the red, not good. But again, don't be upset if your dysbiosis index comes back in the green and you knew for sure they had dysbiosis and that was what you're going to treat and that was going to solve the IBS kind of thing. Because even though the overall picture might not be too bad, there can still be like a singular pathogen that's bad enough that we want to treat that. So a little bit, we do still want to look at the line by line. And I wouldn't make all my decisions based on the dysbiosis index. It's a helpful start. It's not the finish line. And then here are our key findings. So it just gives us a quick way to look at what's going on, to see what's happening. So as we want to expand the standard of care, really microbiome is the marker of the future, right? We talk about this all the time, how it is anti-inflammatory, how it sends systemic signals to decrease inflammation, to balance immune function. And yet, if we got this back and there was no commensal bacteria and there was nothing dysbiotic and all we saw was no growth of bifidobacter and this person was having like 20 bowel movements a day and depression, we'd probably be like, well, I thought there's going to be a pathogen. I don't know. I don't know what we're going to do now. No, that is a positive finding. So we know bifidobacter is anti-inflammatory. Also, no fault of the stool test. It's just nothing is absolutely, perfect, right? So if you see no growth bifidobacter and also eyeball lactobacillus, no growth lactobacillus, those are gram-positive bacteria. And what competes with them are gram-negative bacteria. And a lot of our gram-negative bacteria shed lipopolysaccharides. And those lipopolysaccharides kill off our good, healthy flora. So do consider that there could be something competing with it, even if it's not showing up. Again, there are more bugs in our gut than there are stars in the Milky Way, right? We've all heard that. So, we're never going to be able to measure every single thing that was out there. If we could, that test would be a gajillion dollars and it wouldn't be clinically really useful anyway. So look for these patterns. Look for some of the lines within the lines. If you see no growth of some of your best gram-positive bacteria, probably something gram-negative competing with it. And then what do we do about that? Well, gram-negative bacteria hate berberine, for example, so we can reach for a berberine, and we know that gram-negative bacteria shed lipopolysaccharides that increase our risk of cardiovascular disease. Berberine decreases glucose, decreases inflammatory lipids, turns on our exercise pathways, and turns on GLP-1. So again, we can use a berberine even without knowing a specific bug because it's so broad spectrum and non-invasive. And so our medicine gives us this comfort from being able to read between the lines and use these things that are going to be effective to our patients. So, but this one we'd be ecstatic with, right? Because we'd be saying, okay, you got the Klebsiella, increases autoimmunity, you got more Enterobacter, you got a 4+, that's bad. So definitely some clear positives here. But you don't have to have something red and bright like that to have a meaningful test result. So now we're looking at, again, flora. And again, in general, most of our normal flora is that it's normal, it's healthy. But again, you want to be in the middle, in the green. So eyeball this for what things are way out of line. And in this example, not a lot, some things in the yellow. So I'd be telling the patient, you've got good diversity, things are looking good here. But also clue in on the color guide that they have given you, because even though patterns are where it's at, There are some bugs that have just exceptional research with exceptional depth. And so those we do want to weight more. And so, for example, so you don't always see that's because this is normal flora. So you don't, it's gray, it's shaded out here. But when you see that it's blue, if it gets down into this blue zone, that means there's strong research that suggests that that one should not be low. And, same thing, occasionally over here, here's Bacteroides. And what you see is that there's no red to this one. So occasionally here and there, there's not an upper limit. And so really, pay attention to that, because you don't have to memorize good, bad, ugly kind of thing. The test does it for you. And so we'll look at our viruses and then and our pathogenic bacteria, our parasites. So for example, Firmicutes, Bacteroides ratio, that is something that we would talk about having a increased or decreased Firmicutes ratio. Could be regarded as dysbiosis, but when it is high, it's associated with more weight gain, and when it's low, more irritable bowel disease. And that there's some newer research on that ratio that says it might not be as tight as considered, because, for example, so if if the ratio is flipped, then we'd have more Bacteroides, and that can produce lipopolysaccharides, and that too can cause obesity as well. But looking at some of these patterns together, then lactobacillus, and even looking at lactobacillus bifido relative to your enterococcus, because when you have lower amounts, that means you have more of an aging microbiome and more of an obese microbiome as well. But again, you don't really have to memorize that ratio. We already knew lactobacillus and bifidobacter being low were not great. And Akkermansia, their research talks about it being a strong candidate for drug development because of what it does. But again, it does use the mucin lining when it's high. So when it's high, we're not really saying, well, we want to kill Akkermansia. And by the way, there's more ways to increase Akkermansia than giving it. Berberine increases Akkermansia. Fasting increases Akkermansia, and or a ketogenic diet. Things like kale and cranberries increase it too. So we've got a number of ways of doing that. But if it's high, okay, yeah, I could chew the mucin lining. So I probably want to reach for some demulcents. I want to reach for slippery elm. I want to reach for plantain. That's going to protect the lining. And just in general, while you work with the patient, that should come back into balance as you do that. We do see some research in Parkinson's with high Akkermansia. I suspect that one day we'll learn that it goes up in response to inflammation, that it's more of a response to an inflammatory load. It's trying to help us out. And so again, well, what's the downside? Choose the mucosal lining, protect the mucosal lining. So of course, the microbiome is immune regulatory. And so we're all aware of that. But here's a study about probiotics and colds or flu-like symptoms. And so just even a demonstration. And so here they're looking at BIO7, looking at these subspecies in terms of bacteria. And what they saw was that relative to the placebo group, it reduced, just a probiotic reduced incidence of fevers by 53%, coughing by 41%, runny nose 28%. And so again, my point is that the most meaningful thing that we can do to improve immune function is to treat a poor microbiome. And that could be cancer, or that could be a kiddo who just keeps getting colds and flus. But this is why it's so important. Like if you talk to Richard Horowitz, for example, who New York Times bestsellers in terms of Lyme disease, whatnot. Yeah, of course, he spends his practice treating Lyme. But do you think he doesn't do a stool test? Absolutely not. He does those, probably almost as routinely as a diagnostic test for Lyme. Why? Because the major way to boost immune immune function is through the gut. So a Lyme patient, a mold patient, a cancer patient, right? Like, again, like I said, it's not a beta glucan or a vitamin C. It's what is happening in the gut lining here. And so that will improve it overall. So here we see species, subspecies like Lactobacillus HN001, respiratory infections, but also increasing secretory IgA. So I'm going to speak about secretory IgA, and I love this marker. This is another one that even if there's no pathogen, you don't see a lot, go look at secretory IgA. If it's high or if it's low, that means a lot. So if it's high, the body is fighting something. That is your immune system. It goes up in response to something. So either a bug that maybe didn't show up. And one thing that anecdotally causes a screeching high secretory IgA, parasites. So if you see that, and especially like traveled and got symptoms and there's a clinical picture to match, think about it. And again, in our world, we can use berberine for parasites. We can use Artemisia for parasites, and Artemisia is also anti-cancer. So because these therapies are so non-invasive, they give us a wide window to be able to treat things like that. Secretory IgA can go up because of foods too, but it's more likely to be because of some bug. Now, when it's on the low end, that is also a part and positive. I mean, that is 80% of your immune system, but I would argue that we could suggest that it might even be 90%, 95%, because if secretory IgA is low, it sends a signal through dendritic cells to prime the rest of the immune system. And you see a decrease in Treg cells that keep the immune system in balance, and you see an increase in Th2 and Th17 response that make us more inflamed. And so if we see low secretory IgA, that is having an effect on the systemic immune system as well, and we absolutely need to be mindful of that. So good, healthy bacteria, like I said, you get a stool test back on your mold patient, and the mold patient, right? It's not looking for aflatoxins, but if they have no microbiome, they're going to reabsorb every single aflatoxin. We have to build that microbiome so that absorbs the aflatoxin before it gets in circulation. So our good healthy flora make these opposite of LPS. They make these signals that prevent infections. They break into biofilm. So you have a healthy microbiome. It's going to keep other things from setting up shop. It potentiates the biofilm. Lactobacillus, of course, helps us make certain B vitamins. It can be antimicrobial. It decreases histamine. So we knew there was a lot of benefit out there. If we do see, for example, overgrowth of reuteri, then or we want good levels of reuteri because it will compete against H. pylori. By the way, if you're looking for other things to treat H. pylori, your sulforaphane from glucosinolates do that, and your D-glyceride licorice, look for, it's a trademarked form. It's not a brand. It's called Gut Guard. It has 6 studies that show just that alone, eradicating H. pylori. But again, we don't want it to come back. So that's looking to the microbiome to make sure that's the case. So our lactobacillus from H. pylori to infections to viruses to fungus, it competes and it will take up space where they would be. It also increases secretory IgA. So I was mentioning what an important benchmark secretory IgA is. Oh, I thought, right, okay. And so absolutely. I mean, if this is it, it is 80% of the immune system, and it primes the rest of the immune system. So if that is lower than 51, that I draw a line down the middle, and I want to see people at least, more 75, 80 and up to make sure that, more like 125 and up to make sure they're in the top 50th percentile here, because that's their immune system. I don't want you in the bottom 50 percentile for immune function. And so really it is a quite meaningful marker. Another thing, and this is another thing that I teach people in the class in terms of evaluating stool tests out there. There are some stool tests that don't show a lower end to secretory IgA. That just doesn't match the clinical data. The clinical data definitely talks about low secretory IgA. and the impact on the body. And so if you see a test that does that, I would suggest that it's ignoring a large part of the clinical literature. So a low secretory IgA, your immune system's compromised, and your systemic immune system goes on fire because of this. It sends signals through dendritic cells and says something is attacking us out here. We are under siege. I don't know, and we're all worn down on the front line, so our back line needs to amp up. And boom. So you start to make more inflammatory T cells, or if you have an IgG titer to foods, those stay up longer because the systemic immune system says, I don't know, but I better stay on heightened alert because our first line defense is so low. It's not doing what it should. So Saccharomyces increases secretory IgA, like we looked at. Lactobacillus increases secretory IgA. I'm very fond of vitamin A, and even at very low doses, 5,000 IUs is enough. I'll use 25,000 IUs. You don't get toxicity with that, but even 5,000 is enough to increase the secretory IgA, and it's a big deal. 80% immune system, and it primes the rest of our immune system. And it gives us clues. If it's low and no pathogen shows up, there's still a reason that it was low. And likely the body has been fighting and fighting and fighting so long that now the immune system's bottomed out. I also love immunoglobulins to increase a secretory IgA as strategies there. Oh, and there you go. So Saccharomyces, Lactobacillus, glutamine does it as well. So things like immunoglobulins that are either from the human specific ones, and I guess a little more appropriately, they're pathogen specific. You can source those from eggs, and so then they basically. We all make immunoglobulins. As mothers, we make immunoglobulins. It's one of the major things we pass in breast milk. This is why you see colostrum derived, or even, but we have them systemically. So serum derived from a cow with a chick. So egg derived obviously comes from a chicken. They inoculate the chicken, and that will create specific antibodies in the egg. They inoculate the chicken with a lot of these bugs that show up in a stool test. There's Shigella, Salmonella, Strep, Staph. And so those specific antibodies are targeted for gut-based bugs, regardless. So they help with dysbiosis, but they also increase secretory IgA. And so we make lots of this. We make gram amounts all the time. So we need to feed the body the things that we need in order to do it. So when we see it low, it is a big deal. And also file this away. There are bugs out there that chew up and degrade secretory IgA. Blastocyst is one of them, so you're going to see that in your parasitology. And we all know that it's hard to get rid of, right? It tends to come back. Well, the reason it comes back is because it has specific proteases that degrade our local immune system as a way for it to survive. Candida does the same thing as well. So if you have ever gotten a test back and maybe there's not a lot of pathogens, but there was like maybe a 2+ or a 3+ or a decent growth of Candida, and their secretory IgA is super low. And you're like, well, but they're here for mold. Do I really need to treat this Candida? I don't know. Well, if you see a low secretory IgA, even with a little yeast, like even a +1, ask the questions. Did you have a yeasty beer the day before? But if there's nothing yeasty in the diet, then yeah, I'm treating the +1 because Candida makes proteases as well that degrade secretory IgA. So functionally, it's creating a mess. And so I do want to get rid of it. And, those small amounts of Candida that you're like, it's a huge chronic fatigue patient. Does a +1 Candida matter? Probably in a huge chronic fatigue patient, it is worth treating. Why? Because Candida drives a Th17 response, and that's that part of the immune system that's so inflammatory, right? That's what drove a cytokine storm to make all those cytokines that were so damaging. It pushed Th17. Also, in terms of that's the part of the immune system that's upregulated with rheumatoid arthritis or with Crohn's. So these really inflammatory things that are going on in our system. So all that being said, a little bit of Candida is a big deal. If there's a clinical picture that correlates brain fog, bloating, fatigue, And if you think that they have a Th17 pushed condition, then getting rid of that yeast will help to bring that immune system down. And if you see a low secretory IgA and a little bit of yeast, well, it's eroding the immune system. So I would be treating in that capacity too. So like I said, those secretory IgA, what they have identified is that, yes, it quelches bacteria and prevents virulence, but also it sends these signals through the lymphoid tissue to signal the rest of the immune system. And so this is another thing in our real gentle, our real sensitive patients, a SIBO patient, this is a great example. They can't tolerate any of the therapy. They feel just as bad from the therapy as they do from the condition, just everything. Well, if they had a low secretory IgA, start there. Build up that secretory IgA because it will passively wall off the bad bacteria. And so now, instead of bacteria lysing open from our antimicrobials causing a die-off reaction, our secretory IgA gently walls it off. It just doesn't adhere. It's not breaking open. It's not causing a lot of this distress. That being said, this is a good way to kind of look at it and think about it. And this is fascinating too. So you have nothing else but a low secretory IgA. That's a lot because it's 80% of the immune system plus. Second, something knocked it down. So think about it that way. Third, when you have low secretory IgA, you're going to treat pathogens with more oxidative burst and commensal bacteria. So that bacteria that like, well, maybe sometimes it's bad, but it's not a strict pathogen. How much do we care? If your secretory IgA is low and you have commensal bacteria and no other pathogens, then your body starts to say, why is the secretory IgA low? Maybe it's this commensal guy, make a stronger oxidative burst to it. So you'll start to you'll have an explosion to commensal bacteria that you weren't having before with low secretory IgA. So thinking about things to reduce those reactive oxygen species in that scenario, you're just more fragile. So these low secretory IgA patients, think about them as just having a thin lining. And like, for example, when they do research with IBD patients, well, and even when they do mouse models and that kind of thing, what they see is that you just come on to planet Earth with a thinner lining and just kind of everything bothers you and upsets you. So you see this low secretory IgA, you might realize that, okay, this is someone that we need to do some building first because they're not going to tolerate things until we get to that point. And so when you see that, then you've got, a lot to work with, despite one thing on your stool test. That's a lot of ground to cover clinically in terms of how we're going to treat. They talk about how it's kind of this Trojan horse scenario that happens. And if we see a low secretory IgA, yes, bugs you can fight so long that your immune system is bottomed out, but we should always think about asking the stress questions. Secretory IgA is very fragile in the face of stress. So this means all of a sudden you might be treating the gut with various adrenal support because you need to lower the glucocorticoids in order to get the secretory IgA up. And so again, gives us a lot of directions to go in. High secretory IgA, figure out if there's a food you're reacting to, if there's a bug you're reacting to, you're going to treat it with immunoglobulins, probiotics, vitamin A. Low secretory IgA, you see some of the same things. Why do you see vitamin A on each list? Well, if it's high, I want to continue to support the body's ability to make it, to fight what's going on. However, if it's low, we got to build it back up. So that's why you see some similar things on both sides of those results. Okay, so here's that yeast scenario I was mentioning. I don't know, there's a little bit of yeast. It's rare, but they do have brain fog. Do I care? Ask diet questions, make sure there's nothing yeasty in the diet. And then from there, I think even a little bit of rare yeast pushes you a bit in a Th17 direction. So if they have a clinical picture that would match, then yes, I would be thinking about treating it. I love caprylic acid, often combining caprylic acid with some N-acetylcysteine. N-acetylcysteine is probably the go-to biofilm breaker for Candida. In fact, if you're doing some amino acid testing through doctor's data, this is like fascinating to witness. And you ever see a bunch of cysteine in the urine from an amino acid, and then you ask them, okay, well, you're taking glutathione, you're taking N-acetylcysteine, it's spilling out, you're taking too much. Nope, I'm not taking any of those things, not taking any of those things. What could be going on there? Yeast hates cysteine so much that it will work to kick it out of the body so it doesn't injure it. So you can see on your doctor's data amino acid testing, sometimes that one spills out in excess, sometimes it's the yeast kicking it out. So if you ever see that pattern, think back to what's going on with more yeast there. And so these are strict pathogens. You never want them. They're not great. This is easy. It's not like there's any green over here by the upper end. So we know what to do with these, and we even more specifically know what to do with these because, like I said, unlike other only PCR tests, once they find a pathogen, they grow it out and put those specific agents next to exactly that bug, not that bug in general. So it's much better in that capacity. Okay, so now we get to look at some of our digestive enzymes. So elastase, there's really not a lot of impact in terms of being high, and that's why you don't see a red end. You're just all the way up. We want good pancreatic enzymes, and elastase is it's a byproduct from our pancreatic enzyme, so it lets us know how many we're making. Very, 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 very rarely you might see someone with an elastase really cranked up there, and you're like, well, why would that be? Ask if they ate a fatty meal. We'll make more in response to that. But there is a teensy bit of research that talks about high elastase being associated with more weight gain. Kind of makes sense. Like an abundance of enzymes, you're absorbing even more than you should. Again, doesn't happen very often. And it's not like I'm going to shut down the pancreas because of this. I'm going to try to figure out, I'm just going to treat the gut in general, and something like that should normalize. And again, big clue here because there's not a red end here. So really, there's not a lot of clinical consequence there. And so sometimes you see labs that will overrepresent both ends or not show like a low end to a secretory IgA. Those are things that we pay attention to. So then from there, all of our inflammatory markers, we know that if calprotectin is elevated, we want to make sure that we rule out irritable bowel disease. Lactoferrin, I just think, is fascinating. The other place that you can find lactoferrin besides the gut is in breast milk. And that is because you're trying to set up a healthy microbiome. Now, lactoferrin goes up in response to bacteria. It's there to kill it. White blood cells make it as well, but that's why it's in breast milk too, to help the baby set up a appropriate microbiome. And this is why some colostrum products also have some lactoferrin in there. So if I see a lactoferrin, neutrophils make it. So I'm thinking bacteria, I'm thinking more dysbiosis, particularly if I see that, and therefore more berberines. But all of these are a big deal. But again, like just because the inflammatory markers are normal doesn't mean that you have a normal stool test. Next is our secretory IgA that I've been talking about. And so here we see clearly that there is both a low and a high end. And that's very important for 80% of your immune system. And then here we see short chain fatty acids. And again, let's say nothing comes back, nothing anywhere else. And the only thing you have are low short chain fatty acids. Well, you've wasted the patient's money and you shouldn't have done it in the first place. No, not at all. And that's, we do tests to rule things out as well. So to rule things in, but to rule them out. But I know as a clinician, we're thinking, I'm expecting to see this. And then when it's not there, we're like, well, why is it not there? We want it to be there to give us something to treat. So this scenario, nothing came back, but you have low short chain fatty acids. And I'll even say, they're not even all low. Butyrate's low, and acetate is low, and everything else is normal. Well, no matter where your short chain fatty acid is at, even if it's in range, They are highly anti-inflammatory, highly comparable to prednisone without side effects. And so you're low normal and you're having gut-based inflammation, the more you push those up, the better the patient's going to do. So I'm not satisfied to just see them clinging on to the bottom of range. Okay, now in my scenario, butyrate was low and acetate was low. Well, acetate has really profound research in terms of, for example, crossing the blood-brain barrier and having us feel more satiated. So let's say you have somebody and weight gain is the big deal, and the only thing is they have a low acetate. You have found a pertinent positive that crosses the blood-brain barrier and tells us to feel more full. Let's say this maybe another way. Maybe you're working with patient in terms of weight loss, and maybe you're using a GLP-1 agonist in order to do that. And now they've hit their target weight and you want them to stay there. This is a great time to think about running a stool test, because a lot of dysbiotic bacteria will cause us to gain weight. An absence of a healthy microbiome causes us to gain weight. An absence of short-chain fatty acids causes us to gain weight. And so why did they gain weight in the first place? This gives us a way to say, okay, let's fix this. Now transition you off your GLP-1 and you'll do better in terms of maintaining the weight there. So it's a huge opportunity. Butyrate, highly anti-cancer, and yes, colon cancer, but it also shows up in the research reducing breast cancer and prostate cancer. Why? Because you absorb some of it and it's anti-inflammatory. Propionate tells tight junctions to be stronger. It has a lot of research with autoimmunity, but then again, you're like, okay, she's just talking about how wonderful short chain acids are. The more of them, the better. Let's say everything was normal and propionate was high. Do you tell them to quit eating fiber? No, never. Maybe only short term if someone's bloating terribly, but we've got to figure out a way to get fiber in the body. So my point is, it's probably more about the dysbiosis and correcting it. And even though propionate is overwhelmingly beneficial, you can have an overgrowth of certain flora that make that short chain fatty acid. So again, they're out of balance. And it's not that we're going to take away fiber. We're just going to do our work to decrease gut-based inflammation. You can see that one go up in some autistic kiddos. And so again, it tells us more about the dysbiotic bacteria. It doesn't say fiber's bad. And then your pH, you might say, okay, they have a low pH. They're too acidic. I need to get them off digestive enzymes. Also not really about your hydrochloric acid. When you see pH out of range, it's more about dysbiotic flora. So again, even if they didn't come back in the test, if you see these patterns, you know something must be going on to create that, and treating that becomes appropriate. Of course, beta-glucuronidase, we know, represents the health of our estrobolome, which is a true word. It's the microbiome as it relates to estrogen metabolism. And so when glucuronidase is up, we know that we have more dysbiotic bacteria. It's cleaving those estrogen metabolites. They're coming back into the body. And we want to think about our calcium D glucarate. Glucuronidation happens locally in the gut lining as well as the liver. So working to detox both places and also to make sure that we're removing those estrogen metabolites. So I have some information, and the slides are going to be given out. And so there's more information in here about various short-chain fatty acids, even communication with the brain. We've all heard about zonulin telling tight junctions to open. And we've even heard about how zonulin does a similar thing to our blood-brain barrier, makes it leaky. So research talks about and when the blood-brain barrier is leaky, you're more likely to have depression, anxiety, brain fog. And one of the things that competes with zonulin at the blood-brain barrier are your short-chain fatty acids. So you get a depressed patient, you run a stool test, nothing comes back but a low short-chain fatty acids. That is a pertinent positive. They compete with zonulin at the blood-brain barrier, shut the blood-brain barrier down, and you have less brain fog when your blood-brain barrier is less porous. So we absorb them into the brain. They're signals for the blood-brain barrier. They tell us of all these things that are going on. And so there's a lot more information in here. So for example, here is a scenario where you have very good data that they are at risk for autoimmunity or what's driving their autoimmunity, and not a single thing on here is a pathogen. Low butyrate makes you at risk. Low acetate, low propionate. All of those things increase your Treg function, which puts the immune system back in balance. If your Bacteroides is low, then that decreases Treg activation. And if your secretory IgA is low, that means you're going to have less IL-10, and IL-10 increases Treg cells. So there was no Candida, there was no pathogenic bacteria, but this is still, and really all I've said was, you didn't have a healthy microbiome to make your good short-chain fatty acids. We already knew that was a risk factor for autoimmunity, but for some reason, when we see it on the paper, we feel like we haven't discovered what we should. And so really starting to look at it in different perspectives can be helpful in terms of grabbing that clinical data that we need to make sure that we're helping patients appropriately. So like I said, we need to reduce inflammation, improve nutritional levels, decrease toxicity, minimize stress, and improve diet and lifestyle, and gut-based health is so important to all of that. If you have enjoyed what you've heard, check me out at Origins Incubator, Practice Management Group. I teach the clinical piece. Scott Radigan is a lawyer who specializes in functional medicine. He teaches the legal arm, and Linda teaches the business piece. Again, she had a wait list after 6 months moving to a new state and starting a brand new practice. So, and she did that while her kids were in school from 8 to 3, creating a six-digit figure for her salary for herself. And we will be at IFM as Origins Incubator, so come by and say hello. I'm sure Dr. Data will be there too, so come say hello and check us out. And I want to just stop there to make sure that I get to questions.